I think I became interested in epilepsy during my studies in Strasbourg, where I was a medical student at the Strasbourg University. So it was in my fourth year of medical studies, and I was student in Edouard Hirsch department. And definitely, I knew before that I would like to be a neurologist, and I discovered epilepsy with Professor Hirsch, and I decided that it's very interesting, and definitely I want to do that. And why? Because at this stage, I was almost fascinated by the fact that we can better understand how the brain works through the clinical anatomy correlation of epilepsy surgery workup. It was very, very interesting and different from what I saw in other neurological specialties. In terms of treatment, we cannot speak about treatment gaps in France. We are quite lucky. Our system has a lot of problems, but allow us to prescribe everything we want without significant restriction. The main issue in France is sometimes we have significant delays between the European authorization for a new treatment and our ability to prescribe it in France. For instance, in the Dravet syndrome, prescription of fenfluramine for the moment is very restricted and only authorized in Dravet syndrome, and I cannot prescribe it in Lennox-Gastaut syndrome, whereas I think in Germany it's feasible. So I know that in the future I will be able, but usually I have 2 to 3 years delays between Germany and France to initiation of new treatment. But at the end, eventually, I can prescribe everything I want without significant restriction. This is for for drugs. For epilepsy surgery, we do not have a real gap. We can organize everything we want. We can provide to patients, I think, the top level pre-surgical workup. The main issue currently in the French hospital are related to the lack of staff. So we cannot use all beds that we have. For instance, in my department, almost 50% of beds are closed because of the lack of staff. So this is not a real treatment gap if we consider all issues that are facing by other countries. So it's a problem of very well-developed countries, perhaps, but the waiting list is pretty long now for the French patients to initiate their pre-surgical evaluation, but mainly because of the problem of organization within hospital, but not of a more complicated problem. So we hope that can be solved in the future. So for tuberous sclerosis, the first thing I think is important to remind to all neurologists is that, especially in adults, it's not only a neurological disease, but we also have to monitor the kidney and the lung and the liver. It's very important. And if we only focus on the brain in our adult patient and forget to collaborate with nephrologists and specialists of lung, we will have a lot of issues. Then if we focused on epilepsy and tuberous sclerosis, the two other things which are important. First, some patients can be eligible for epilepsy surgery, even if there are a lot of tubers. We can sometimes find a restricted, a very focused epileptogenic zone. It needs a very comprehensive pre-surgical workup. For in almost all cases, this pre-surgical workup must include invasive recording using a CEG, but in a small proportion of patients, you can achieve seizure freedom of epilepsy surgery. So it's very important to take that to keep this aspect in mind, including and this is the third point, including in children in whom the presentation includes generalized seizure or at least spasm. So it's well demonstrated that in young children with tuberous sclerosis, even with patterns suggestive of generalized seizure, including epileptic spasm, sometimes it's feasible to propose epilepsy surgery, and it will improve the neurodevelopment of this young patient. For heterotopia, I think that the main aspect to keep in mind that, again, even if I don't think that a reasonable number of patients will benefit from cortical resection. It will not work. It does not mean that we have nothing to propose. Now we can propose pre-surgical evaluation and to propose that the eventually SEEG to perform thermocoagulations, and a significant number of patients benefit from thermocoagulations. Sometimes we have to repeat and to reprocess because after first SEEG, the patient is schizophrenic during 1 year or 2 years and then relapse. But it worth to retry and to reprocess and to perform a second procedure to complete thermocoagulation of the heterotopia, but also of the neocortex, because this type of epilepsy are defined by a very complex network, and just focusing on the heterotopia is not enough, I think. But again, we have to be optimistic and not stop any non-drugs, non-pharmacological treatment. We can propose something, and it's important to have this aspect in mind.